Thank you so much for that fantastic introduction. So as was mentioned, my name is Benji Ozynski. I'm a sleep medicine doctor and health tech entrepreneur. In my career, I've been extremely fortunate to see all angles of healthcare. Seeing angle, obviously, as a patient, as we all patients, as a practicing doctor, and as a health tech entrepreneur, where I interface with thousands of medical practices of all types. And I'm really passionate about this topic because, and it sounds quite obvious when we talk about it, but healthcare is extremely blind. We get snippets, 15 to 20 minute snippets of our patients' health journeys or disease journeys. But really, diseases begin, progress, and complicate when patients are not sitting in front of us. For many patients, a consultation can be a highly stressful event where they don't remember everything, and continuity of care, engaging with patients and trying to maximize patient care in between visits. In many practices, an afterthought. And I hope by the end of this conversation, I'll convince you that not only from a medical perspective, but from a business and a practice sustainability perspective, putting processes in place and looking at time between visits as an area that we can extend our care and gather invaluable data from our patients is something that we should put into practice. And so, if we look at the literature, up to 42% of our chronic patients will miss their next follow up. And in working with many practices and experiencing this myself, as medical practitioners, we have a bit of a cognitive bias, right? Because we see every day patients who follow up. And that creates a bias in our minds that all of our patients are following up because we're not seeing the patients who don't follow up. In many conversations with colleagues, we often think that, well, actually, our patient base is really compliant because, if we think about it today, we maybe saw 4 or 5 follow ups. But the blind spot of what we don't see of our patients not following up can be absolutely tremendous. And of course, it goes without saying that patients who are lost to follow up, they show poorer health outcomes, poorer disease control, higher admission and readmission rates, and of course, increased mortality. And I think if we think about it, the almost paradoxical phenomenon is that the patients who are most at risk and the most comorbid are often the ones who don't follow up and who become lost to follow up. And really, without putting in proper systems in place, not only to track our patients and when they should be following up and if they do or don't, but to engage with those patients and to bring them back to our practice so we can take care of them, um, then we really are sitting at the back foot. And as I alluded to earlier, with this cognitive bias, that we don't actually have a deep understanding of our patient base as a population. The saying goes, what gets measured gets managed. But if we can't measure that non-compliance rate and we don't have systems in place to track it, there's no way that we can improve it. So I'll give just two kind of opposite scenarios and talk a little bit about them. And each of which happens every day in many medical practices. And we'll use hypertension as an example. So if we look at kind of the patient journey of somebody in an not very ideal situation of not being followed up. So patient gets diagnosed with high blood pressure, they get put on antihypertensives, and they are told just to come back in 6 weeks. It's not documented, and there's no way of communicating with that patient afterwards, or even understanding in 6 weeks time that this particular patient should be following up. So of course there's no recall, the patient doesn't book. Blood pressure becomes uncontrolled because during that 6 weeks, the patient developed intolerable side effects to the medication. And because we know, for the most part, hypertension is an asymptomatic condition, they think, well, I actually feel fine. Let's just leave it. And then, of course, we know the complications of hypertension. And at some point, that patient presents to the emergency room with, one of pick your complication of hypertension. What also happens, just to elaborate a little bit on that scenario, and we know this, where oftentimes either a chronic condition or the complication of a chronic condition gets diagnosed in casualty, where for many months, if not years, this was a problem. It was left undiagnosed, unmanaged, and it gets picked up unfortunately, when there is an acute event that causes somebody to go to casualty. And this happens every day. We just don't know it's happening because we have no way of tracking it. Scenario number 2 is a return date is booked before the patient leaves. There's a system in place to track that patient comes back. And if not, there are measures in place to communicate with that patient to ensure that they do come back. So side effects are identified and they're addressed early. Blood pressure is rechecked. Medication is either titrated or changed. That complication is prevented. And, at a basic level, we can implement tracking and recall systems for appointments. And we can even go more advanced where there are ways for patients to track and communicate symptoms and side effects in between visits. We often think that the prescription is the treatment, and once we have prescribed the medication, we've successfully managed the patient. But that's only really half the story. So if we look at uncontrolled hypertension, right, a key point that I want to emphasize is that 60% of patients who are on antihypertensives are not at the optimal blood pressure that they should be. And so if we look at our base of hypertensive patients that are on medication, up to 60% of them are walking around not being controlled. And we know that there's a significant increase in all-cause mortality of patients who have uncontrolled hypertension versus the normotensives. And these patients, they have a prescription, but without follow-up, unfortunately, control is never achieved. And while we think our patients are walking around because we've prescribed them antihypertensives, we've done our job and their blood pressure is controlled, it's almost as if 60% of those patients haven't been initiated on antihypertensive treatment. And then again, so if we look at diabetes as one example, but really this example filters into every chronic condition, where 60% greater risk of hospital admissions for diabetic patients who missed a primary care appointment after previous hospitalization. So the simple act of ensuring that post-discharge, a diabetic patient follows up with their primary care provider can dramatically improve their health outcomes. And the metric being used here is readmission rates. And in fact, if we look at the US and where value-based models are being implemented, value-based funding models, there's a large incentive for healthcare providers, discharging healthcare providers, to ensure that within a 30-day period, those patients aren't readmitted. And in fact, in value-based models, some of the funders overseas will actually not pay or reimburse for readmission if a patient is admitted within 30 days of discharge. And so if we look at, no-shows versus attending diabetic patients, there's a dramatic difference in hospital admission rates. And once again, with diabetes, as is with most chronic conditions, it's the patients who are most at risk that are simultaneously most likely to miss their follow-ups, which I think is quite interesting. So when we talk about what happens in between visits and tracking and engaging with patients, another area is around test results. So engaging with patients, tracking patients, and really filling the gaps between appointments where we can provide care for patients, both in terms of obtaining information from them and providing information to them, is not just around chronic care. It's also around unaction test results. And, obviously being a doctor, we often hear, friends and family speaking about their other experiences at other practices. It's extremely common in our, medical community where a patient will go for a test and they actually have to phone in to obtain those results, right? And again, that gets caught because perhaps the patient is, highly anxious or, they really are concerned about a result. But it's actually quite shocking as to how many test results are just not communicated with patients. And in the literature, it shows missed results, of course, delayed cancer diagnoses, undetected endocrine conditions, missed STIs and PRD, and failure to change antibiotics because of that. And looking at a study that showed in the UK, so UK data, So abnormal result follow-up failures were found in 83% of GP practices audited, right? And nearly half of test result negligence claims involved failure to notify the patient. And I'll discuss a little bit later about the medico-legal implications of it. However, where a result is received and not communicated uh, or not actioned is legally worse than a result never received, because there's obviously proof that we've seen it, but we didn't action it. And once again, when we're consulting, I think we need to almost reframe things. Um, and that, yes, consulting is our primary responsibility. But it just happens where in a lot of practices we get super busy and communicating test results becomes almost an afterthought. But if we can kind of pause and implement a proper process in order to track the test results and ensure that no test results get missed, and where test results are received, that every patient gets communicated with. If we put those systems in place, systems solve a lot of problems. Not only do we not run into potential misdiagnoses and really poor health outcomes, but we also prevent a lot of medico-legal liability. And again, if there's no systems in place to both track and communicate with patients, it's so easy for a test result to slip through the cracks or radiology result to slip through the cracks. And so not only with regards to chronic care is tracking and engagement important between follow-ups, but communicating test results is equally important, both of which, if not done, can lead to poor health outcomes, but also medico-legal liability. The next area is in regards to medication adherence, right? So we've covered chronic disease care, we've covered communicating test results. Medication adherence is another massive topic where the patients aren't sitting in front of us when they make the decision to either not go and get the medication that's been prescribed or to stop their medication in between visits. That happens currently in a massive blind spot within healthcare where patients are not sitting in our practice. So the World Health Organization, and this is quite a common number, so adherence to long-term chronic disease therapy averages only 50% in developed countries and lower in developing countries, right? So if we look at both our public and our private healthcare sectors, at best, we are looking at about a 50% adherence rate for long-term chronic disease therapy, which is really dismal. And up to 20% of patients, they never fill their first prescription. For example, in asthma maintenance therapy, adherence can be as low as 28%. And 68% of patients, so recently discharged patients, said that a follow-up call would have improved their medication adherence. They were expecting contact. And the gap between prescribing and adherence is where, of course, chronic diseases progress. And from our perspective, following up is the only clinical tool that closes it. And so, if we think about how we can put systems in place for something like this, we are in the age of incredible technology. The cost of technology and software is only reducing. There are so many options available to be able to track patients, obtain information from them in terms of symptom tracking, side effect tracking, in a way that doesn't really take away our time too much. Really leveraging technology to almost act as a second arm of our care that can do most of the heavy lifting, most of the hard work, and most of the time consuming activities, that can execute a good follow up strategy, a good tracking strategy to ensure that if patients are experiencing doubt about a particular medication, if they're experiencing side effects about a particular medication, if they are exposed to misinformation about particular medication, which we know is just out there, and it's a massive problem. We have to put ourselves in a position where a patient feels comfortable, but also has the channels to communicate that with us so that we can intervene and we can counteract that misinformation. We can manage the side effects, switch medication if needed. And there's a way for us to do that, bilateral communication with the patient, specifically with regards to medication adherence, and even more importantly, when initiating a treatment for the first time, can really improve medication adherence and therefore really improve that patient's condition and their chronic condition. And once again, if we look from an ethics perspective, so initiating treatment without planned follow up is ethically complete. And we all know if it's not written down, then it didn't happen. And so if we kind of think about three levels of following up, what can happen. So, level number one is we say to the patient, just as they're at the door, cool, come see us in 3 weeks or 6 weeks or 6 months, right? Undocumented, patients have had to take in a lot of information in that consultation, especially when starting a new medication, and they go off on their way and then they don't follow up, right? If we look, of course, the health outcome implications of that, we're all aware, but the medical legal implications of that are also significant. Level number two is documenting it in our notes that, a patient counsel to follow up in 3 weeks. That is better. But again, patients may or may not. And we can see from the data, a lot of them not only won't follow up, but may never go and fill that prescription, right? And, the ultimate level that we really want to get to is, of course, level one and two being done, but having a system in place where that patient will be communicated with, they will be tracked to ensure that they come back, and there are measures in place to recall that patient should they not come back. From a health outcome perspective, that's optimal, but from a medical legal perspective, that is also optimal, right? Documented evidence that in your notes, not only was the patient informed to follow up, but there's also documented communication attempts with that patient, right? And so we, of course, always want to mitigate medical legal liability, but of course, primarily we want to ensure optimal health outcomes in every patient that we see. And once again, it's about thinking about the system that one needs to put in place in order to achieve this. If it's just done as almost an afterthought, then of course, it will slip through the cracks. There's undocumented, advice given to patients. And so it's really about thinking about the systems that one can put in place to make this as easy and seamless as possible, and not having to rely on, us being able to do it, or admin staff being able to do it kind of in an ad hoc way. So systematize all of these when it comes to following up. Okay. And I think this might be new information. And because, we often hear like, I just can't baby my patients. It's their responsibility to come back. And, unlike the lawyer of Michael DeBrolio who says, well, if it wasn't your fault, it's not your problem. Unfortunately, that may work for car accidents, but in our industry, that's not the case, right? And so even though it's not our responsibility, or we may think it's not our responsibility, it can become our problem very quickly. So failure to follow up is among the most cited reasons for HPCSA complaints and negligence claims. And I think that's new information, which is quite interesting. So we're going to talk a bit later about safety netting, okay? But for the purposes of now, verbally communicating follow-up times, red flag signs and symptoms, uh, it's not enough, right? So legally, it never happened. And I think we all know that. So if it's not in the notes, it didn't happen. But I take it a step further and say we should also have documented evidence of communication or communication attempts with the patient, right? And again, abnormal results received but not actioned is knowledge without response. And that's really the worst legal position that we can find ourselves in, right? And so, what defines knowledge? Is it a notification through your Empath and Lancet app? Is it an email? Because we do get those. And so most of the time, it would be assumed that we did have the means of viewing the result, and we did receive the result. And so if that's not communicated, that automatically puts us in the receive but not action category, which is a very precarious situation and legal situation to be in. So again, looking at HPCSA, what is our obligation? So act expediently to protect patients from risk for any reason. So guidelines on records, follow-up arrangements must be documented, not assumed. And even if they are explicitly communicated to the patient verbally in our practice, If they're not documented, they weren't done. And initiating chronic treatment without a documented follow-up plan is a breach of these guidelines. And so I think it's important just to understand how the HPCSA views uh, these things and the potential medico-legal risk we can find ourselves in if these are not attended to properly. And once again, that cognitive bias of, every day we feel like we're following up with patients, we're sending blood results. It can just take one or two to slip through the cracks, and we find ourselves dealing with this. And so once again, systems, systems, systems. And of course, something that we all know, continuity of care, saving lives. And we've looked at various areas thus far of where we can improve continuity of care. So let's take a little bit of a look at the evidence. And once again, I think, all of these will be quite intuitive. And if they weren't by this point, they should be. So 9 out of 13 studies in a systematic review found continuity of GP care significantly protects against all-cause mortality, right? And many different studies showing that. But I think what's quite interesting, looking at the data and looking at the outcomes of this research is, if we know a patient well and we develop a relationship with a patient, a relationship with a patient is really important for a couple reasons. So, we know our patients, we know when something's wrong, and adherence is a lot better if, communicated by a medical practitioner, provider, where patients have a relationship with. And so just looking at some of the research, so GP continuity is independently associated with lower mortality. And that's the most comprehensive review to date. We're looking at a hell of a lot of patients. So, over 757,000 patients, higher continuity index linked to fewer emergency admissions. And once again, just talking through the mechanism, it's quite clear when we have a relationship with patients, they feel more comfortable in communicating their reservations, their objections, their worries, their discomforts, and we are better at judging, their condition from a clinical perspective. And once again, simple post-discharge. And this is, that was from a GP perspective. This is looking at a hospitalist perspective. So 21% lower 30-day readmission risk with structured outpatient follow-up after discharge. And I think the US is a little bit ahead of us in terms of value-based care. But it's a good idea to start thinking about how one can mitigate that 30-day readmission, because it has become part of standard within the value-based care model with many health insurers in the US. And, that post-discharge kind of follow-up of a patient is extremely important. There are so many factors to consider, obviously depending on what they were admitted for, what they have to look for, and a lot can go wrong, a lot can be misunderstood in the discharge process, and a lot can be forgotten. And so looking across some studies, so a 30-day follow-up reduces readmission in patients over the age of 65, and every post-discharge patient that you see within 30 days is measurably less likely to be readmitted. And there's some stats above there just showing across certain conditions. So it's quite important to talk about a concept called safety netting, which I think, every practice and every medical provider should be implementing. So again, we'll apply to 3 levels. And so safety netting really is structured communication of red flags and specific conditions for reconsultations, right? So red flag signs and symptoms, particular side effects on medication, right? It's pretty much as simple as that. And so once again, I'm pretty sure most of us kind of hit level 1 of communicating that to a patient, right? Level 2 would be communicating that to a patient and documenting that we've communicated to the patient in our notes. And really where we want to try and move towards is level 3. So that comprises of 1, 2, but also having a process and a system to be able to communicate that to the patient, uh, post your consultation, and a way for them to communicate that back to us should they occur, and then very swiftly ensuring that that patient can return, or there is a referral pathway that's ready to go with the patient. So safety netting, it's a great concept, also once again quite intuitive, but it's how we execute on that safety netting that can make or break somebody's health outcome, or expose us or protect us from medico-legal liability. And it's only observed in about 64.5% of consultations study, and quality varied widely, even when it did occur. Okay. Another study showed so advice tailored to the individual patient is significantly more likely to be acted upon. And written safety netting reduces reconsultation rates. And again, it protects you legally. And I think we just also have to contextualize safety netting in terms of, is it sufficient to just tell the patient? Are they capable of observing those symptoms or signs themselves, right? So, for example, we see it in sports medicine quite a lot, post concussion. And it's all very well telling the patient to, uh, call us or come back if they are confused. But who's judging that? And so also, another, area that we could look at is safety netting, not just with the patients, but with a patient's primary caregiver or their family or somebody who can monitor for them, including ourselves, right? And once again, leveraging technology in a smart way that can do a lot of the heavy lifting for us when it comes to executing safety netting, checking in with the patient, giving them a process where they can submit red flag signs, red flag symptoms, medication side effects, or the lack thereof, and having that process documented. Again, crucial for health outcomes and equally crucial for medico-legal protection. And this is really an area that I'm really quite passionate about. It's the business side of continuity of care, of patient engagement, and what everyone would get taught very early on in an MBA course. If we look at patients as customers, which they most certainly are in private healthcare, and if we look at our practice as a business, which it certainly is in private healthcare, we need a healthy business so that we can have a sustainable practice, so that we can care for patients. So it's perfectly okay to look at this from the business side, and we should, right? And unfortunately, as doctors, we don't get a lot of business education, but it's really important to create a sustainable business so that we can thrive and therefore our patients can thrive. And so back to kind of our little miniature MBA in 5 minutes, right? So what everybody gets taught is it is much cheaper and more affordable to retain an existing customer than it is to acquire a new customer, right? When we think about growing a practice, we often solely focus on getting new patients, or what you would call in business acquiring new customers, and very little emphasis is put on retaining our existing patients. And that looks like keeping our patients for as long as possible, of course, where appropriate, and having those patients follow up with us regularly, once again, where appropriate, as dictated by our clinical judgment and by clinical guidelines. And if we look at a chronic patient who comes to see us once every 2 years versus a chronic patient that comes and sees us twice a year, if we look at the maths on that over a 10-year period, you can very quickly see we gain a lot more revenue, oftentimes as paid for by the medical aid for a PMB condition, for a patient that follows up regularly versus a patient that follows up sporadically. And many of us will go and spend a hell of a lot of money on websites, on marketing, which is brilliant, and you absolutely should. But an area that us doctors often miss because we just don't have any formal business training is customer retention. And every successful business is really good at customer retention, because it's all very well acquiring a new customer, but if you're losing a customer at the same rate, then your business just never grows. If you put focus into analyzing your patient base, treating your patient base as a population, and understanding who should be following up, and putting automated systems in place to track them, catch them, and engage with them and bring them back. Firstly, patients appreciate it, health outcomes improve, and our business thrives because we all have a patient base. uh, if you look at reasons for whatever discipline you are, why patients should come back, um, and compare that to how many customers you could acquire, in marketing efforts, what you will find very quickly is not only is it a lot more affordable to focus on the existing base and retain them by virtue of keeping them for longer and bringing them back more often, again, where clinically appropriate, it's a lot more sustainable. And obviously, the goal is to do both, but from a business perspective, focusing on your existing base. And that does not necessarily mean just calling them for appointments. It can be patient education to particular cohorts. It can be advising particular cohorts on particular medication about particular side effects. So engaging with that base just for the sake of educating uh, is a very good customer retention or patient retention exercise to do. But of course, keeping track of them and engaging with them where to come back. And so, at this stage, we can see that from a patient health outcome perspective, from a medico-legal perspective, and from a business perspective, it makes absolute sense. Take a step back, put systems in place, and really everybody wins by virtue of the process. And what we found and what I've seen time and time again is patients appreciate communication. Patients appreciate care, right? If it's not going to be you, it's going to be another doctor or it's going to be ChatGPT, right? That's just the reality we face right now. And so we'd much rather patients voicing their concerns to us than, perhaps getting misinformation. Okay. So very quickly, I've spoken about, some more complex things that we can implement, although quite easy nowadays with technology, but some ways that we can, basic ways that everybody can start tomorrow to improve continuity of care. So book the return visit before they leave and have that communicated to the patient, preferably digitally. So we document it in our notes and there's digital confirmation of a communication to the patient about their appointments. That's really good. And if there's a way to track that even better, build a results workflow. So received, reviewed, actioned, and documented, right? A result in your inbox that is an action is a risk accumulating in real time. And once again, not just a health risk for your patient, but a medico-legal risk. And it can be as simple as an Excel spreadsheet, really and truly. And we can, create some more automations if we like. So whatever works for you, whatever you're comfortable with, just create that results workflow where there is tracking and where nothing can slip through the cracks and nothing is left at the mercy of human error. And then document the plan in every consultation. So review date, safety netting, safety netting. Once again, at a minimum, communicate it to the patient and document it in our notes. But even better, if there is communication after the patient leaves, right? Protect your patient and protect your practice. So, the case for continuity of care, patient engagement, and putting effort into our existing base and caring for patients before and after consultations is up to 42% of chronic patients miss follow ups. And we can't see that it's happening. We only see what's in front of us. We have a cognitive bias most of the time where we are heavily biased towards what we see. And even if we are only seeing, you know, 50% of our patients who are meant to follow up, it's a bias that we feel because we are seeing them, they are. But until you actually look at the data objectively, there's no way to measure it. And therefore, there is no way to manage it. Treated but uncontrolled hypertensives carry 2 times the cardiovascular mortality of controlled diseases. And of course, that would go for any condition. Diabetic no-shows after hospitalization face up to 60% greater readmission risk. 77% of doctors had no reliable system for tracking whether abnormal results were actioned. Continuity of care reduces all-cause mortality and is confirmed in the majority of studies done. 30-day post-charge follow-up reduces readmission risk by 21%. book the visit, have the results, workflow, document the plan. Once you've done that, leverage technology to take you that step further. Please don't be afraid of technology. Leverage it to extend your reach of care, to create efficiencies within your practice, to empower you to do a whole lot more for not a whole lot more time expenditure. And with that, I would like to thank everybody for their time. It's been a real honor speaking for everybody. And I suppose now we can open the floor for questions.